Yeah, thanks, Director Huang's kind introduction. Maybe I can partially answer Professor Zheng's question. In National Taiwan University Hospital, if a large tumor burden or advanced HCC, we choose HAIC, there will be no embolization effect. So you know that if we are choosing maybe a large tumor burden for stage B, it is not easily to be treated by TACE. However, we would not like to have post-embolization syndrome or deterioration of liver function, or even in stage C patient with portal vein thrombosis, we may consider hepatic artery infusion chemotherapy. I believe that hepatic artery infusion chemotherapy have been used for many years, but I believe there are two advantages nowadays. One is that in the beginning, they only have the furfurinol protocol, and then they only can combine with target therapy agents such as sorafenib. And then previous study have shown that after combination of local regional therapy, it can have a better objective response rate as compared with systemic therapy. And then the first advantage, I believe, is that the 4-4 regimen, it becomes more efficiency and then less side effects. So in China, you can see that if the tumor is a large tumor, they even prove that the 4-4 HAIC is better than TACE. And then so let's move to our target become, you can imagine that a large tumor with portal vein thrombosis. So today there is bad beats. However, if the size doesn't matter, as President Zhang said, if the size is very big, maybe consider this. So I would like to talk about the intermediate to advanced HCC, and then it's a very common situation in Asia country. So don't worry that because if the tumor is large or BCLC stage C, the HAIC still is a choice for treatment of the HCC. And then we learned a lot from the Kaohsiung Venerable General Hospital. They usually use HAIC followed by lipiodol injection. However, in our institute, the medical oncologist said that they don't accept that. So, however, they can accept that HAIC combined with immunotherapy. So we developed immunotherapy combination with HAIC. We know that nowadays there are a lot of checkpoint inhibitor-based treatment, and including anti-PD-1 and PD-1. And then, however, the local regional control rate may be not so good. If you can use HAIC, you have an additional choice. And then in the beginning, I learned from Professor Liang, you need a very complicated delivery system. You need to do the vascular redistribution to embolize the right gastric artery, gastroduodenal artery, and put a port. And then although you have so much effort, the complication rate is still high, maybe high to 22 to 35%. So, and then sometimes you need to spend a lot of time to to embolize the extrahepatic supply, or if there is some complication, it's also very difficult to remove the port. So the SRE artery access is much better now. And then we, in the beginning, we also learned from Dr. Jialing, yes, you can see that under ultrasound, we usually identify the so-called acromial artery, and then it is not easily to identify the lateral thoracic artery. So in fact, although we call it subclavian artery, in fact, it's punctured the axillary artery. So if the safety zone is that lateral to the thoracoacromial artery, and then our resident also can identify that it usually beneath the pectoralis minor, and then if you puncture this artery, usually very safe. And then we also have some dedicated catheter, although we know that in the beginning we only use Cobra. However, you can see that there are various shapes of hepatic artery. Now we have maybe TIG or Jackie, Sarah, a lot of catheter can be choose. And then after that, we put a catheter and then so it was a trans-arterial approach. So the major concern is that the possible cerebral infarction, and then if the catheter have a redundant shape like this, according to previous literature, the chance of cerebral vascular accident may be increased. But if no redundant, I think it's quite small percentage. So I would like to share this kind of technique in our hospital. So as you can see that the case 1 is a 71-year-old male, Hep B, HCC stage C, without treatment. And as I mentioned that in our hospital, we favor use Firefox plus Atezo and Beba. And then we identify the axillary artery, and then we catheterize to the proper hepatic artery, and then do the chemo infusion. We do this in the same times of admission. So we do Hake first, then they continue admission and then receive Atezo plus Beba. So you can see that in the beginning, we also inject some Lipiodol, and then you can see that the tumor was marked shrinkage. So you can start in this situation, you can treat not only maybe 5 or 7 centimeter tumor, you can treat 10, 20 centimeter HCC is still very good result. And then for this case, you can see that I think it's also more than 20 centimeter HCC, and then it's a non-B, non-C HCC. And then after 3 times Fox plus Atezo and Beva, you can see that there is a complete response after the treatment. And then the other benefit is that we know that if you do the trans-arterial Hake, you can select it to the feeding artery. So you can see that for this case, it's also a stage C patient. And then the first catheter, you can see that the right hepatic artery is supplied from the SMA branch. So we do the, and then in the diagnosed angel, we also found that the left hepatic artery seems come from the celiac trunk. So in the beginning, we put the catheter to replace right hepatic artery first. So you can see very interesting. After 6 cycle Fox, you can see that the right side of the tumor is devascularization with decrease in size. And then the right hepatic artery become normal. So the feeder remain the left hepatic artery to supply the left portion of this tumor. So after that, you can see in the beginning is like this. So after 3 times, you can see that the right side have the devascularization. Then we shift to the left hepatic artery, and then finally get the complete response. I think this is a benefit not given by the implantable port Hake. And then even for the infiltrated HCC, I believe there is also some rule. You can see that this is a 72-year-old female happy HCC, and then there is portal vein thrombosis. This is an infiltrated region here, and then we can do this similar technique with Atezo and Beva. And then we do this. Maybe have 20 patients receive Hake pace combined with Atezo and Beva. The mean age is around 60, and then the happy is the most majority of the patient. And then I believe the most impressive point is here. You can see that 90 patients are up to 11 out. And then you can see that the alpha building is very high, and then all patients have the 100% have the portal vein thrombosis. So our complete response rate can be 50%. The partial response rate can be 55%. So the objective response rate can be 70%, and the disease control rate can be 75%. I remember when I was young, this kind tumor burden, usually survival is less than 3 months. So with this result, I think it's a very good. And then for our technique, you can see that it's very fortunate that we have no cerebral infarction and then only some minor hematoma. After I told you the landmark of the puncture, only some patients have a transient brachial plexus injury. They may tell that there is a numbness, and then there may be some catheter migration, and in one case have catheter occlusion, so no major infarct. So maybe IR can feel also help in the in each stage of HEC. In early stage, we will have RFA and the microwave. In middle age, we have TACE and DAPE TACE. In advanced stage, we have HAIC. So combined with this kind of transartery HAIC and the immunotherapy, I think it's good for large tumor and the tumor with vascular invasion. Thank you for your lesson.